I'm going to get started. So good morning, everybody, and welcome to number 3 of Expanded Province-Wide Rounds. And our topic for today is virtual health, what we do and don't know. And we have today Dr. Bevilacqua and Dr. Singh, as well as the provincial PHSA Virtual Health Office team who will present, Jamie, Emily, Ben, Stephen, and others on behalf of actually all of the province. So without further ado, I'm going to turn it over to Dr. Bevilacqua to talk about virtual health, rethinking how we deliver care. And this is the overview, and Mike will start with some bit of clinical context and background. So over to you, Mike.
Great, yeah, thanks, Adira. Yeah, before we jump into virtual health, I think it is worth just rethinking and framing how it is we deliver renal care in BC, because that's really going to inform how we move forward with our virtual health solutions. None of this is a secret to this group. You're all well versed in this, but it's just as a reminder that we have a wide spectrum of different patients that we see, some that we mostly own, like our dialysis and transplant patients, some of whom have shared care with other providers. We do this within different structures. So again, some of those structures we own, our KCCs, our dialysis units, our transplant services. Some of them are done within hospital. Some of them are out of hospital. It's a mix of out of hospital, a mix of private offices and health authority run offices. So there are various different settings there, each of which have their own implications. And we have this structure here of BC Renal in British Columbia, where really I think the best way to describe that is that all of our renal care is coordinated provincially, but delivered and implemented locally, meaning in each of the health authorities in which these services exist. So it's not just one item that we're talking about when we talk about renal care in BC. There's a whole lot of different moving pieces here. And patient-wise, when we add in the transplant patients, we're talking about 25,000 patients that we provide care for. So a lot of moving parts. If you go to the next slide, Brenda. And whatever of those services we're talking about here in BC, it's all done as a team. And again, we have our team that we kind of have ownership for. There's our renal team, composed of many different people. I tried to make sure I listed everybody there, kind of like an Oscar speech, that I haven't forgotten anyone out, but there's a whole lot of different providers in our renal team. And then we have collaborations with a lot of other people, primary care being a big one, but then there's other specialists and services. And I think the most important thing I want to say about our renal teams is that it's very much an integrated group. These are not parallel services. In other words, there are some clinics that run like that, where somebody might happen to see a physician and they happen to see a dietitian as well. That's not the case here. The patients come and they see a team which is composed of different providers. The difference being that the team works together and provides care together, and maintaining that integrated structure rather than thinking about having parallel or sequential services is very, very important to us. And I think it really underpins everything we do in renal care is coming back to that integrated team. If you go to the next one, Brenda. And oh, yes, skipped one there. Oh, okay, oh, there we go. So the way we think about renal care is very much a longitudinal thing, right? Again, unlike some other specialists services where it might be much more episodic, for the most part, when a patient is a renal patient, they are a renal patient for life, and we follow them through the various trajectories they go through. I have this picture here of peaks and valleys, because I think that really is what our patients and our care provision is. That times their care needs are quite high and there's a lot of activity. And then at other times it comes down a little bit lower and we're kind of into a more maintenance mode. So it's a longitudinal care with these specific events interspersed within it. And if we're to think about the categories of care we deliver, I like these 3 categories that I very much have stolen from Adira of education, surveillance, and navigation. And it really, I think, conceptualizes the different buckets of things that we do for our patients. You can see some of it being very specific, things that might happen within a very defined care environment. Some of them happen within a mix or kind of more loosely defined care environments. So again, there isn't just one way we provide care. It's different, and for a patient, it's going to be different through the course of their life. Next, Brenda. And to make it even more complicated, there's not any one defined way that we interact with our patients. Some of our interactions happen within a clinic setting. Some of them happen between clinic visits, with a phone call in between, or with reviewing labs, or sessions that happen in between clinic visits. And then even when they do come for a clinic visit, it might not be the same combination of services they have. On one visit, they might see just a dietitian. On one visit, they might see a whole team. They might have a specific visit with a social worker. So again, we're interacting in multiple different ways with these patients, both between in visits and between visits. And then we also have documentation needs. We need to document and share information within our team. When we're all in one environment, that's very easy to do. When we're dispersed, maybe a little bit more challenging to share information within the team. And then we need to share our information with others. So any other care providers that touch the patient need to be filled in with what we're doing. If there's a hospital system, of course, it needs to be updated there for when that patient interacts with other hospital services. And then, of course, there's PROMIS, which kind of underpins our renal care in BC. So that documentation also has other moving pieces. We go to next, Brenda. And I'm very proud I made it 4 whole slides without mentioning the word COVID. But of course, we have to talk about how this has really impacted how we deliver renal care. I think probably one of the biggest things is that the physical distancing has really changed our team environment. Rather than having everybody in one area, right side by side, shoulder to shoulder with each other, we're now a little bit more dispersed. It takes away that ability for those hallway conversations or side of the desk conversations that I think really help us deliver care as a team, that ability to informally talk whenever we like. There's different access to people, and I would say there's real changes in access and very much perceptions as well. And by that, I mean, we're not seeing our patients as often face-to-face, and there is value in seeing somebody just face-to-face and shaking their hand, and we can't do that anymore. And some of the perceptions is our environments have changed. When you go into a renal unit now, there's barriers and checkpoints. It's in some way, I've had a patient say it's like entering a military zone, where you have to go through all this screening. You can't see anybody's face anymore because we all have masks and goggles and everything on. So from our patient standpoint, there's an additional level of removal from what we used to have. And as we go forward thinking about how we're going to do this, it's really opened up the fact that there are a lot of human factors in how we deliver care. One of them is what I just described, our ability to interact with one another. But the other is that as we look at different ways of delivering care, we have to consider the technical capacities, both of ourselves and of our patients, any language and cultural needs that will inform the way we deliver that care, and the fact that, frankly, right now, everyone is a little bit afraid and a little bit uncertain of what comes next. And I think we can't underestimate the impact of that enough. So next, Brenda. And as we move into this next phase, I think there's really 2 questions we need to ask ourselves. One is, we've been very fortunate here in BC to have just excellent renal care. And the question is, how do we keep that same gold standard of care, but delivered in a new and unfamiliar way? And what we're going to be talking about today is how we can think of how virtual health and system redesign is going to help address the needs of ourselves as well as our patients. It's a not very hidden secret that we are not going back to the way we've delivered care in the past anytime soon, if ever. So we're really going to have to think about how we can reshape things to deliver that same high quality care. So with that, if we go to the next, I'll turn it over to Dr. Singh, who has been doing telehealth for longer than any of us, and is going to share his experiences with that.
Thank you, Mike. Can you all hear me? Okay, so good morning, everyone. I've been asked to talk about our virtual care model in the North, really representing the pre-COVID era, and share some of the learnings at a higher level with all of you today. So think about stuff until February, and things have obviously changed in the COVID. So next slide, please. So it is a team sport. So this is our Tele-Kidney team in the North. So I'm presenting on behalf of a wonderful, hardworking and collegial, as Mike said, a very interdisciplinary team from our kidney care and transplant clinic. And I want to particularly acknowledge our manager, Mandy Levesque, who's not in the picture, Sherry Yeast, who recently retired, but really contributed to this work, and our clinic lead, Caroline Babbage. Maureen, who's in the picture, made a lot of contribution to the clinic, and Jennifer Platzer, our transplant lead, Lynn Johnson, pharmacist, Shelley, dietitian, and Frank Flood, our collaborator from the Health Authority, Raina Farnes, our project manager, and my colleague nephrologist, Khalid Bashir and Fareen. Next slide, please. So how do we get to tele-kidney care? So in the north, we've had challenges for geography, access to care. As you can imagine, it's a huge province, and Northern Health really caters for a very large geographic area. And a perspective to the ones who are, you know, not familiar, size of the country, France. So we've been, we're dabbling with telehealth for quite a few years and started doing this more, integrating since 2013 in our clinic, and use different ways to do a telehealth clinic on the side and thinking about how we can integrate telehealth visits to our flow of the clinic. So we took on a project between 2016 and 19 within Tele-Kidney. It was called Tele-Kidney Care in a regional program. And really, the idea was enabling a synchronous video conference. So at that time, not telephone, using our health authority, like Northern Health's established network, which was secure and ticked all the boxes for confidentiality. And we actually, with the help of our health authority, were able to invest a lot in the technology infrastructure. So we bought a number of, state-of-art, beautiful screens. There were Cisco DX80 machines, which looked at a very nice, high-definition screen on our end. And we had those in every, team member's office. So it was a touch screen. They could connect very easily with the patients on the remote side. So we had 5 or 6 in our KCC, which was shared with the transplant clinic. And we also updated a number of remote sites to this technology. Next slide, please. So the format, like Mike was saying, remained interdisciplinary. So that was the spirit. We did not want to do one-to-one, visits. We wanted patients to be seen in the usual flow of the clinic. And scheduling was done by our nursing unit clerks. There were appointments every 50 to 20 minutes, which each of the provider of the team from their office. And the whole idea was to integrate this in the usual flow of the clinic. So we're not actually doing something else on the side. It's part of the current workflow. And that took quite a while. Next slide. So the goals, what we're trying to do here was patients, give more choice to patients and better access. Clearly, geography was our big motivator at that time, but you can think in the current pandemic crisis we've had with COVID, how it could suddenly change very quickly. And also for us to maintain continuity of, care, longitudinal care was very key, and prevent lapses due to weather and distances. And for the team, for making it easy to innovate ways to really integrate this into the model we had. And of course, at the same time, thinking about rural, remote communities to engage primary care providers to provide access and build relationship, and have a model of more relationship-based care with our providers. And really one of the overarching goal of better outcomes for kidney patients. Next slide, please. So briefly, some of the outputs we've had, as you can see in this graph, you can see the numbers are on the y-axis and the time is on the x-axis. So this is data for just over 3 years. And we started with our clinic numbers. So this is, each dot represents 28 days. It is a fiscal period. And the purple dots are total visits, and the red ones are the ones virtually or telehealth. So we started a bit slow, and over time, our clinic numbers for virtual care and overall increased. And what is interesting is that this increase was largely attributed to the video conferencing or telehealth appointments. Next slide, please. This is another example of showing the percentage of patient visits delivered over the 3 years, split by 2 different kinds of clinics, CKD and transplant. And you can see CKD, or KCC as we call it now, started slow with 10%, 11% for transplant, 2016, 17. And the green areas are the fluorescent ones are the KCC in-person appointments. And you can see there is an increase over time and maintaining around 30% of virtual clinic appointments virtually over telehealth over time. Next slide, please. Yes, this was one of our main key kidney indicator to see that did we see a change in our referral patterns. So one of our challenges in the north was late referral, and you know, looking at the 2019 and 20 data, our mean GFR is touch above 30 now. It used to be close to 20 5 years ago. So, you know, one of the association is that the access and the ease from primary care perspective and also the patients is helping us deliver more timely care to the patients, especially in the rural remote areas. Next slide, please. And yes, this is again, as I said, geography was a big challenge, and you can see Prince George as a red dot, and the kilometers. You know, we cater to above 750 kilometers, which is, you know, similar to some of the other jurisdictions' regional health programs. But what we were able to do between 2016 and 19 was reach out much more to the circles outside Prince George. So they increased, but the biggest increase we saw was, you know, people traveling from 200 kilometers or even further away. And that was the case over the 3 years. Next slide, please. So interesting work that was done with the help of the university was to look at the environmental impact. So, you know, clearly patient travel has impact on costs. So traveling by car, meal, accommodation, and we had to have a big province. So, you know, it's interesting to see what you can save in terms of, you know, income of people's employment and carbon emissions. So, you know, just an example that during the duration of the project over 3 years, there was 215 tons of carbon emissions that were reduced or saved. And that's equivalent to, you know, 40 vehicles of a year's worth of emission. So that is interesting that this has positive impacts outside the health that we look at. Next slide, please. So this is an interesting unintended consequence, but very positive. And I'm pleased to say that the trend in our home dialysis program continues to increase. So, you know, this data goes back to 2014, and we've seen a huge change since 2016. Our PD uptake has gone quite way up, and for the region we are, you know, our prevalence is close to, for home dialysis, is close to 40%, which is fairly high. And what I can see is that there is a linkage between the time and the uptake of peritoneal dialysis during the project. Next slide, please. So patient experience. So again, we did a lot of surveys over time, the 3 years of the project, and this is an example of the patient surveys, and the numbers is 102, and this was a survey which was done over the telephone. So interestingly, and I hope you can see this, that still people, you know, patients overwhelmingly like the convenience of this video appointments or virtual care. But a lot of them prefer still to see the providers in person. So there's a question, I prefer to see my healthcare providing using telehealth rather than in person. So a lot of them prefer to see in person rather than telehealth alone, which is an interesting one. And also, you know, enabling patients to attend appointments more regularly so that there are less lapses and on the longitudinal care perspective. And many, up to 15 to 20%, would not have traveled for their appointments if they did not have that option. So that is another access to care, perspective. Next slide, please. So this is just overall satisfaction, strongly agree, overwhelming support for virtual care, but keeping in mind, this is, one part of the overall picture. Next slide, please. So team perspective, overall positive, but given that we transitioned from telehealth to a significant amount of ongoing video conferencing appointments, the team felt there was a concern in the quality of care provided. And that was mostly from the relationships and rapport with the patients, with the team, because instead of a person, you have a screen. And the patients could often say they don't remember the names of the providers. It was just different, not the same. And overall satisfaction and morale of the team improved over time. So what we learned is that it is hard to integrate, but at the same time, this can be an adjunct rather than the only mode of delivering care. Next slide, please. So what did we learn? We learned that telehealth, clearly using the video conferencing part that we did, is a viable adjunct, but an adjunct to connecting with patients for clinical care. It definitely saves time, traveling, money, and the environment. Patients love it. They find it very useful. It can be used to engage primary care providers. We've had primary care docs sitting with the patients during appointments, and that's been very fruitful. What we also learned that it does not replace in-person visits, and which is very important and key for developing relationship. We're talking longitudinal. We look after these patients for the rest of their lives, whether they even get a transplant or dialysis. So this is very important. And of course, we went through a lot of required resources, training, and it was a lot of teamwork and effort that was put into developing this program that we had. It needs built-in quality improvement, continuous quality improvement, because that's the only way you can refine this, and needs to be incorporated as a service delivery model. Next slide. So this is my last slide. Where do we go next? So from March onwards, the virtual care scenario in the province, in the country, or should I say the whole world, has changed completely. We're using telephone, we're using Zoom, we're using many other platforms for integrating care with our patients. But what is very important is that these are modes to connect with patients. So these are not the way means. So we tailor this to the need of the patient or the clinical care they need. We do need, standards of care so that we can provide the best care at the right time, at the right place. And what is very important, and we're in BC very fortunate to engage patients to refine this so that we can learn from patients to continue with those patient-provider relationships, which are very key in longitudinal chronic disease care. So I'll be handing over from here to Jamie and her team, who are going to talk about Healthy at Home program from a provincial perspective. Over to you. Thank you.
Great, thanks so much, Anurag. Thanks everyone for having us here today. We're very excited to talk about the Healthy at Home project and how we are going to start working together and what our real goals are during this time. And then if we can go to the next slide, please. So the Healthy at Home project, a very, very quick background, is a project that helps support the vulnerable patients or those with pre-existing conditions at home using virtual and digital health tools. PHSA was given a priority by the Ministry of Health of how we can make sure during this COVID time when access to care really has changed because of COVID, how can we make sure that there's no side effect or we prevent that deterioration that could happen and try and keep people in their home but still keep them healthy. So we've been working with 5 major groups, BC Renal and yourselves being one of them. We're also working with Cardiac Services BC, BC Transplant, an informal group of respiratory group, and BC Cancer to see how can we help keep those patients healthy in their home using these virtual health tools. So our goals are really to monitor and intervene early to prevent that deterioration of their pre-existing condition, to keep patients out of the clinical setting in order to reduce exposure to COVID-19, and then to attempt to care for unstable patients in their own home instead of hospital. If we can go to the next slide, please. As mentioned, so we're working with these 5 groups. We can go to the next slide. And what we found very quickly is some major priorities that came out of this work. The first 4 of which being clinical priorities that the Office of Virtual Health had recognized prior to COVID. And then the bottom 2 are things that have come up since COVID started and since we've done this engagement with those 5 groups. So what has come out is virtual visits, remote patient monitoring, online treatment and resources, clinical digital messaging, telephone support lines, and mobile health. The particular priority we're working with BC Renal and everyone on to begin with is the anywhere to anywhere virtual visits. So as Anurag was describing, that was a room-based telehealth or room-based teleconferencing where a provider and a patient needs to be in a specific room where the equipment is set up, but that room is most likely closer to the patient's home. And as we saw from the great presentation, has some really great results with that. But what anywhere to anywhere virtual health is and how it differs is the provider and the patient could be anywhere. So the provider could be in their home, could be in the hospital, could be in their office, and same with the patient. They could be in a family's home, their own home. They could be anywhere. So that's what makes anywhere to anywhere virtual visits. If we could go to the next slide, please. So this is the life cycle, and this is a little bit of what to expect as we start to move forward with this work and start to work with you more. We started with engagement. So this is, we engaged the BC Renal leadership team. The 5 groups I had mentioned, all of the leadership teams were brought together, and to start to talk about the vision and hear about what the networks, different networks and the clinicians within those networks were needing in order to help keep their patients healthy at home. And now we're starting to move into discovery. So discovery is getting down into more of the details, hearing from specific clinics and hearing from you what it is that you need around virtual visits and how we can support you. We're also going to work very closely with the regional health authorities' virtual health teams in this and going forward as well. We'll talk a little bit more about how we all work together at the end, but each health authority does have a virtual health team, and we'll very closely collaborate to try and move this forward together. So the clinics we're starting with right now are St. Paul's Hospital, VGH, and Royal Inland. And here we're now trying to work with individual clinics to determine what are the specific needs, what's working, what's not working, and how can we help to change that going forward, either with a solution or by helping to redesign the workflows, which is going into planning, which would come next. So it's really getting into that care transformation. And as Mike said, how can we provide care differently in this world and in this virtual world? And we want to ensure that the care you are providing is as good, if not better, than the care you're already giving. You're already giving such excellent care. So it's really thinking about those workflows, really thinking about the way we are doing it, that we can ensure a similar or better result, but maybe we're having to do it in a different way, and that will come in planning. Then we'll get to execution. And within execution, that's where we'll really talk about implementing the actual solution. This is where from pre-identified potential training or education needs, we'll provide in some way and plan how to provide that education so that clinicians and support staff are able to know what to do, both within the workflows and within whatever system we pick. And are able to use it at the optimal level. And an evaluation is very important, as Anurag mentioned, really taking a quality improvement approach to this and a continuous quality improvement approach. So really seeing what's working, what's not working, changing that, and then reevaluating it as we can start to get better and better. And then looking into the future would be scaling. If we can go to the next slide, please. So I'm going to hand it over to Steve, and he's just going to talk a little bit about the few features of a few of the virtual visit solutions you may have been hearing about.
You there?
Steve, you might be muted.
Yeah. Yeah, Steve, you're muted.
That's good.
Yeah.
Yeah, that's good.
Thanks.
All right. Can you hear me now?
Yes.
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 Not now. You seem to be muted again.
All right. Can you hear me now?
Yes.
Mike, give me a thumbs up. I can see you on the screen if you can hear me. Thank you. All right. Perfect. Let's get started again. All right. Good morning, everyone. I'm Steve Walstaff, and I'm clinical analyst at the Healthy at Home program. Today, I plan to give you a quick overview of some virtual health solutions that can be implemented in your clinics. I want to clarify my intent is not to recommend or direct you to which solution to choose. This is more of a high-level review of some of the qualities and constraints for each tool. As we begin working with you and your regional health authorities to determine which is the best solution, we'll be considering. Unfortunately, my sound is very choppy and I want to use my phone. Apparently, I guess we can't do it that way. So I'll try to get as close to the computer microphone as possible here. Also, if you have any questions, you know some functionality that I might have missed, please write it in the Q&A and the team will answer your questions or make note of your comments. So Zoom, you probably heard of Zoom and most likely are on today. Today I'm going to talk to you specifically for healthcare. So Zoom for healthcare is similar to Zoom in that it's a virtual care video conference platform that connects patients to the healthcare provider. Okay, so I'm getting some messages, it's hard to hear me. Ben, are you able to?
Yeah. Hey, Stephen. How about I take over from here?
Yeah.
Good morning, everybody. My name is Ben. I'm a project manager on the virtual Healthy at Home initiative. I'll just go ahead and give a quick highlight of these tools. As Stephen was mentioning, keep in mind, we're not trying to make a recommendation today. It's really to bring a high-level overview of some of these tools and to help bring a framework that there are different nuances to these tools that will kind of influence our decision on the recommendation. As Mike mentioned, there are different aspects and values that you provide to your patients, like education and navigation. And so what does it mean for a tool to help you provide education to a patient versus helping them navigate through other various clinical care providers and other members of their care team? And so I'm hoping that when we're starting to discover with you and start to assess these tools and workflows, that you have an open mind into what could possibly be introduced for you. So starting off with Zoom, it's something that you've definitely heard of since the COVID-19 release or crisis. It's used in a variety of industries, and it's available for those providing virtual health services in British Columbia. Go ahead and press next. It's a one-to-one, one-to-many, and many-to-one solution and tool to allow you to connect to patients and their families, and then have multiple providers or care team members within the session meeting with the patient as well. It has a webinar feature that allows you to provide effective health education for staff and patients. Currently, it is a tool that is deployed by PHSA OVH and offers support and technical services and support. We're looking into providing patient support for Zoom end users in the future as well. Next slide, please. Zoom does bring some limitations, such as scheduling requires a third-party tool such as Outlook Some of you may have already started using Zoom, and you understand that there are some things that require you to invite others through your Outlook or through a third-party scheduling tool. And it requires extra steps, and it's something that you have to navigate in terms of what employee information, what contact information are you exposing to patients. The waiting room that Zoom does offer is more of a, it's more of a gate to the actual meeting that you have with a patient. And it's important to remember that, because the waiting room doesn't necessarily parallel the waiting rooms that you would have in a clinic. And it's a nuance that we would have to go into further detail when we work with you. In addition to that, it doesn't have the capabilities of sending out meeting reminders for patients and providers. And we've certainly heard feedback from clinical programs on this as a requirement. Next slide, please. InTouch is another virtual health solution and tool. It's specifically designed and modeled to assist with healthcare, where Zoom fits a variety of industries. InTouch Health is specific to meeting the workflows regarding outpatient and inpatient care. Next slide, please. Similar to Zoom, it provides the same features of one-to-one, one-to-many, and many-to-one. It allows the ability to schedule within the tool, but additionally it allows end users and patients to schedule, which is a nice feature for many different clinics. In contrast to Zoom, it does allow appointment reminders. It allows you to provide or upload clinical documentation, and it has features that allow you to set up pre-visit surveys and post-visit questionnaires, and gather information from the patient prior or post the session that you hold. Next slide, please. InTouch, it doesn't allow you to call into a meeting in the sense that you can't use a phone line. It is a tool that is more reliant on the desktop and mobile applications that you would need patients to download to their tools, to their mobile device or their desktop. Similarly, as well as the providers. And one thing with the InTouch I'll just quickly highlight is the waiting room feature is much more dynamic as opposed to Zoom, where you're able to see the queue and get a live feed of the waiting time for each patient inside your waiting room. The InTouch, it's best to think about it as it's built around the patient and their experience working through the clinic. And so the waiting room is much more dynamic than Zoom. Next slide. DoxyMe is a telemedicine solution designed for practices of varying sizes. It's out of the box, meaning that it's ready to use pretty quickly with quick deployment. And it allows the patient or the provider to access each other just simply through a URL website link. And that can be sent out via email or text. Next slide, please. If you've heard of DoxyMe before, you've probably heard that it's very simple to use. It's you can introduce it quickly and start pretty efficiently. There's no app that's needed. You click the URL. It's all hosted on your Google Chrome, your web browser. It has a waiting room feature. It's not as dynamic as InTouch, but it does have a few things that cater to clinical workflow. You can message the patient while they're in the waiting room, while you're in another session with a client, and allows file sharing for things like sharing clinical records and then things like that. So next slide. With the fact that it is very simple to use, it tends to have limitations with the quality and its ability to perhaps scale and grow and be a more robust solution for complex clinical workflows. Because it doesn't have a desktop app or a mobile app, it has video quality issues when you start to introduce group visits, and bringing in different family members or perhaps different members of the care team. There are potential privacy and security risks that you have to work through when you're introducing new workflows, just because you're using the same link theoretically for your meeting room, and have to abide by certain privacy practices and start to take a more thorough eye on certain risks that you would incur there. At this time, Doxy.me is not a solution that is supported by PHSA, meaning that we don't have a support team in place to provide patient or providers technical support. And so, yeah, that's thank you for the time, and I'll be more than happy to answer questions in the Q&A. Next slide, please.
Great, thanks, Ben. So we're going to touch a little bit on what's next, as well as how, I saw the question, with PHSA and the regional health authorities, we're going to touch on how we're working together as well. If we can go to the next slide, please. So what's next? We are starting with 3 clinics, as I mentioned at the top, Royal Inland, St. Paul's, and VGH. So this is where we're starting to really gather the information about your current state, gather information around what some of the needs are, and we'll start to work through the workflows in collaboration with the regional health authorities. After that, we can use what we've learned at Royal Inland, St. Paul's, and VGH to help use almost as a template. From what we're hearing, the KCC clinics across the province are fairly similar with definite differences. So approaching it using a potential future state workflow, which means how are things going to happen in a future state world with virtual health tools, using that and seeing where it makes sense to align the clinics across the province and where those differences do need to occur. And we'll also be working with the clinics to determine, again, in collaboration with the regional health authorities, virtual health teams, working with them to determine the educational needs and supports and provide that. If we could go to the next slide, please. So a couple things on what you can do now if we're waiting. We're trying to work through as fast as we possibly can, but we do need to start somewhere and we'll keep going through. So if we can go to the next slide, please. So this is what you can do now, is really determine and work on the readiness and some of the potential aspects before we dive into the work. Readiness is something we do tend to look at before we start a virtual health initiative. However, COVID has really made us move forward in a very, very short period of time, and we have to move forward with different virtual health options. But being able to think about some of the categories that I have on the next slide are things we will also help do, and questions we'll have for you when we first start to meet with you. But if you're able to take the questions on the next slide, think about, do some thinking around them, maybe some information gathering within your own clinic, that will really help us move the process forward. If you could go to the next slide, please. And so these are a few things you can think about now, and these are things we will ask you and we'll work with you as we move forward. But again, if you just gather your thoughts around it and are able to do some thinking, it would be helpful. So really understanding the current state, this is something that we'll need to do and we'll ask you lots of questions about, which is really, how are you doing this now? How was it pre-COVID? How are things during COVID? What's working well in what you're doing now during this COVID time, and what might we want to change? Also, staffing and leadership, so who can work with us to help understand the current state, help understand what is needed, what might need to change, build those future state workflows or how things can look. And then also, who would be the approver of any of those changes? And then really thinking through, what are you trying to achieve? Are we trying to achieve a recreation of the in-person workflows? Are we open to doing different aspects differently and wanting to look into that? Are there other things you were thinking of doing in the past that you may want to incorporate into this new workflow or new way of being? So what is it that we're trying to achieve? And then determining some metrics. Are there some metrics your clinic or as BC Renal you currently gather that we could use, similar to what Anurag had presented, that we can use to track and see how we're doing and see how the patients and the team and the care, and so we're able to track and see, is this working? And if it's not, what's not working, so we can change it. So understanding and just doing some thinking around those metrics. And then patient involvement. Do you currently have any patient advisors that you work with? that you would want involved in this work. Yeah, if we could go to the next slide, please. So I'll hand this off to Emily, one of the directors of the Office of Virtual Health, to talk about how PHSA and the Regional Health Authority virtual health teams are working together.
Thanks, Jamie. Hopefully everybody can hear me. So the Healthy at Home initiative is part of the PHSA's Office of Virtual Health, and the teams are one big team. And as with all of the PHSA's Office of Virtual Health supported initiatives, we collaborate closely with the virtual health teams in all of the health authorities. So our approach, we try to think about what are some, across the province, what are some common items that we can look at. So in terms of, could we have some common workflows? Could we have some common metrics? Some of the things that Jamie has already mentioned. So that's the role of PHSA's Office of Virtual Health, to think about common elements as we implement virtual health initiatives across the province. So we work closely with the BC Renal team. And then across each health authority, the virtual health team in that health authority works closely with the renal team in that clinic. So for example, Interior Health, we're working closely with Sean Berglund, who's the virtual health manager, and he's supporting the Interior Health Clinic with the sort of hands-on implementation support. So we work with Sean and help him with whatever he needs, and help identify some of the elements within that he's doing in the Interior Clinic that could be common provincial elements. So that's how we work with all of the virtual health teams. We've actually, since COVID, we've set up multiple provincial groups for virtual health. So we meet weekly with virtual health clinical and operational leaders to talk about all of the virtual health implementation that's happening across the province. Could I have the next slide, please? So within each health authority, these are the key contacts for you to reach out to if you want to talk a little bit more about what virtual health implementation looks like within your health authority. So I think these slides will probably be shared after, so you can feel free to reach out to these people if you have any further questions. Next slide, please. That's the end. Thank you so much.
So thank you all for that presentation and overview. People have been asking some questions in the Q&A, so I'll sort of read some of them. I think the time frame for the pilots is one of the big questions, given that there's a lot of excitement and a bit of anxiety about delaying, and yet from what you've shown us, it's not as simple, or it can be much more complicated than simply flipping a switch. So any sense from the VGH St. Paul's and Royal Inland, some kind of a time frame that would allow people to manage their expectations?
We're gonna try and move as quickly as we can. It's a bit of a difficult question that I'm reluctant to give an exact time frame, because it can vary depending on the clinic, what their timing is in order to be able to engage with us, what we're looking to do. I will say we're looking at the pilots to be within a matter of weeks. How many weeks, I'm not 100% sure, but we are trying to move this forward as quickly as we can. We understand the enthusiasm and the anticipation to want to move forward. So we have kicked off with Royal Inland last week. We're kicking off with St. Paul's next week, and VGH has had a couple of meetings already with their regional team and have moved forward fairly quickly. So it sort of will depend. As we finish with one clinic, we'll most likely be able to pick up others, but we're hoping within weeks. Is our ultimate goal, but it can vary. Yeah.
Anurag, I think you might have answered some of them, but the biggest unforeseen challenge when you started the telehealth program?
Yes, so I think there were quite a few challenges. First was learning a new way of doing providing care virtually. was one learning curve as a team. But I think technical support, because we were relying on the health authority or facility to facility connection, that was quite a challenge. And upgrading technology was quite a big one. So what is very important is when we plan something for the future, we use the technology we have right now. And everything has limitations, but technology does change. And it is expensive and costs a lot of money. Like, we invested a lot of money in buying the equipment we did, and a lot of that in today's world could be, you know, if I use the word, obsolete. So now we're hoping to connect with Zoom and all those platforms. So I think a way to mitigate the risk of technology changing is important, and that was our challenge. The other part is the remote support. So our challenge was getting patients to a facility, and it's been brought up in another question, where the clinical care, at least we could get blood pressures and so on. It wasn't easy all the time, but there was some support available. And again, I think if you're reaching patients home as the next step, that is something, if we can look at how we can support virtual care, which is different from providing care virtually, is important to find a provincial solution to that. So I think technical and remote patient support are two major ones, because our patient population is so complex. They have so many comorbidities, and they need help. And if you're thinking virtually, it needs to be comprehensive.
And one of the questions Daniel asked is, you know, is there any possibility of supporting things like blood pressure cuffs for people that can't afford them, or it's an essential part of the care? And I think that's a broader question. And if there is an equitable way for us to ensure that we can do that, that's important for us to look at. But in the first instance, as you said, the technology. I guess this is a general question. I'm not sure if the OVH people have thought about this, but the cultural considerations for cultural safety and interpretation with virtual health for our First Nations, but also for our other non-English speaking, non-Canadian born patients who in our world comprises up to 35 or 40% of any given clinic, depending on where you are in the province, right?
Yeah, that's a great question. In terms of the other languages, this is something that we've definitely thought of, that comes up a fair bit. There's sort of two aspects to it, and one is, can the platform be in other languages? And then the other is, how can we bring translators into the actual clinic or virtual visit appointment? So any platform that's able to have that sort of one-to-many would be able to bring a translator in, so it would just be thinking through those processes. Some of the platforms that we're looking at do have potentials for other languages, and from what our vendors are telling us, what languages they are increasing all the time. So it's definitely something on the radar for most people. In terms of the cultural safety and First Nations aspect, I can't comment on that right now. I don't know, Emily, if the Office of Virtual Health prior had done any work around here.
I know I don't think I can really comment on that either, but I know that we've started working closely with First Nations Health Authority, Megan Hunt at First Nations Health Authority. So we can connect with them and try to answer this question after.
Yeah. Great. And there was a question about what should the health authorities who are not part of the pilot, like what should those other groups do in the interim? And I guess if, you know, the slide that you showed, Jamie, with the various questions that people need to answer, identify a champion. I think the other thing is in our renal community to stay connected to, and maybe we can have regular check-ins with across the KCCs or something, Mike, or the other clinics from those that are doing the pilot, because I think the more people like learn with their colleagues, it'll be faster for them to move forward. But Jamie, maybe you could.
Yeah, agreed. Oh, sorry, I'm not sorry, Jamie. Yeah, agreed. You know, and we're doing that where we're having the operations and management leads of every KCC meet every couple of weeks to discuss exactly this. One of the big points I'd want to mention is one of the goals here is to avoid unnecessary duplication of work. So if your local site and your local health authority, IT people want to start working on this, one of the biggest bodies of work is that workflow mapping that Jamie is working on with the 3 sites. And I'd hate to see multiple different people doing this and duplicating those efforts. So even just letting them know that this is happening, you know, Jamie's team is reaching out to each of those sites, but if they're aware this process is going, we can all kind of coordinate efforts rather than 2 different people doing the same thing. I'm
going to jump in and say, I think Mike and Nadia at VGH have also got some of these process maps. So maybe, I don't know, Mike or Nadia, if you're on, if you want to comment, but I think that sharing in real time of the process maps will save everybody a lot of extra work, because modifying one of those diagrams is a lot easier than starting from scratch. But Mike Copeland, are you on, or Nadia, want to comment? Oh, I think you have to unmute.
I'm not sure if they can.
Yeah, they may not be able to.
But they have shared it, I know, with Jamie, because you're exactly right. They actually were out of the gate a little bit faster, and they've actually shared that with this team here to help inform that work as well.
Great.
I don't know, Jamie, if you have anything to add about that.
No, I think those were great answers. Yeah.
Well, it's 8:28. There were 112 people on the call at one time. We're down to 99 as people go off into their day. I think this has been really useful to set the stage and of, you know, both collaboration as well as metered enthusiasm and excitement to move forward quickly. I think it is an opportunity for us to not just deliver care using a platform, but really rethink how we're doing care and for whom. But to always remember, as Anurag and others have said, that this doesn't replace in-person, and it's not instead of, it's an adjunct. And how best to figure that out, and who gets in-person when versus virtual when, is one of the other pieces of the workflow that needs to be worked out as well. But that's more a principles than a flow thing. So I'll thank everybody for making the time, and for all of our panelists, and for your presentations. And again, like everything else, please do comment on this. These are posted on the Renal Agency website, so you can go back and look at the talks. Thanks again, and stay tuned. We have another exciting expanded rounds next week, where we're going to talk about ethical care in the time of COVID, and dialysis allocation during surges and things. So another really interesting, pertinent thing to the way that we're all being forced to think. So again, thanks everybody for your participation, for the questions and answers. I think we've answered all of the questions, either typing or in person, and Anurag for sharing. Great. Thanks everybody.
Thank you, everyone.